permission, sir, should I start with the live now? So, greetings and a warm welcome to all the dignitaries present here. I am Shwastika from Clarinet, serving as allocation session assistant to ensure a seamless experience. Clarinet is India's most trusted and widely used digital platform, offering a multitude of enriching services exclusively for doctors. Clarinet is elated to be chosen as digital partner for this event organized by Indian Society of Anesthesiologists Pudukkottai City Branch. So today's focus would be Pediatric Anesthesia TEF. Let's begin today's session, for which I would like to invite Dr. A.L.Meenakshi Sundaram sir, who holds degrees in MBBS, DA, MD, Dean and DME at Government Medical Colleges, Theni, Chennai, Professor of Anesthesiology, Thanjavur and Tirunelveli Medical Colleges, and he is also Academic Chairman of Indian Society of Anesthesiologists, Pudukkottai City Branch. Over to you, sir.
Thank you, Clarinet, for your continuous support. At the outset, I request Dr. Munian, our City Branch President, to offer his presidential address.
Sir, good evening, sir. Good evening, all, sir. I am Dr. K. Munian, President IAC, Pudukkottai City Branch. It's my honor to welcome you all for the online webinar conducted every week on Wednesday in the name of Pudukkottai Bhudhan. Today we are conducting 10th episode of second edition of Pudukkottai Bhudhan. Our association represents the collective voice of a specialty dedicated for promoting the highest standard of anesthesia care, education, like our online webinar conducted by Pudukkottai ISA branch and research. Last week we conducted online webinar on the thyroid toxicosis and anesthesiologist perspective. 933 delegates were attended, which was taken by the speakers from Rajasthan. And also today we are conducting a webinar topic of pediatric anesthesia and tracheo usage, which is a very elaborate subject. The speakers are waiting to share their experience. Dr. Akhila, Andhra Medical College, Visakhapatnam, will speak on the Ayre TP system. Why we are using this system? It is a low resistance and minimal dead space. And also it uses, there are many uses of Ayre TP system. It used in neonatal resuscitation, CPAP, and mechanical ventilation, oxygen therapy, independent, no need for mechanical ventilation. It also benefits consistent and controlled pressure, provides people for maintaining FRC, and also easy to use. It also provides heater and humidified gas delivery system. Madam, we give detailed explanation and discussion regarding its Ayre TPs and its modifications. On the second topic of preoperative assessment of tracheal fistula by Vaddi Preethi, Assistant Professor, Andhra Medical College, Visakhapatnam. On preoperative assessment, the tracheal fistula emphasizes the importance of thorough evaluation to ensure optimal outcome. Preoperative assessment, a comprehensive preoperative assessment, is crucial in identifying the potential challenges and optimizing the patient's condition before surgery. These include the respiratory status, evaluating the respiratory status, including the presence of any respiratory distress complication to determine the best anesthesia management strategy. Cardiac status. The tracheal esophageal fistula patient will also have some other congenital anomalies like cardiac anomalies, renal agenesis, and also vertebral anomalies and limb anomalies. These anomalies will challenge our surgery and the anesthesia impact. Anesthesia will impact the anesthetic management. Airway management, evaluating the airway for potential difficulties in endotracheal intubations. Lab test, we have to do routine laboratory tests. We will know the all tests like CBC, electrolytic panel, echo, ECG, and chest radiograph. Optimization strategy may include respiratory management and cardiac management. By emphasizing the importance of the thorough preoperative assessment on this topic, would highlight the need for multidisciplinary approach to ensure the optimal outcome for patients with the tracheal esophageal fistula. Welcome, madam, for your elaborate discussion. And anesthetic management of tracheal esophageal fistula by Dr. Venkata Krishnan, Assistant Professor, Andhra Medical College, Visakhapatnam. The includes a pre-induction consideration, preoperative assessment, as I already told, a fasting status, ensuring the patient is promptly fasted to minimize the risk of aspiration. Induction and maintenance, rapid sequence induction, consider the RSI to minimize the risk of aspiration, especially in patients with high risk of regurgitations. Endotracheal intubation, secure the airway with the endotracheal tube to prevent aspiration and ensure adequate ventilation. In tracheal esophageal fistula, the tip of the endotracheal tube should be distal to the airway and above the carina. Anesthetic agent, select the anesthetic agents to provide the hemodynamic and adequate analgesia. Intraoperative management, ventilator strategy, improvement ventilator strategy that minimize the risk of barotrauma and ensure adequate oxygenation. Monitoring as usual, we have to monitor BP, saturation, heart rate, and others. Fluid management, careful fluid management to offer any hypovolemia and also perfusion according to their weight. Post-op care, also we got to again routine monitoring. Nutrition, gradually introduce the oral feed as tolerated by the patient to improve the nutrition and healing. And challenges and complications. Aspiration pneumonia is a major potential complications. We have to be ready to manage the complication. And also cardiac complication also very much we are facing, like hypotension and arrhythmias. We should be prepared for that to manage such a complication. Welcome, sir. Sir will give elaborate discussion regarding anesthetic management TEF. Welcome, sir. The whole session will be moderated by Aparanji Koturi, Professor, Andhra Medical College, Visakhapatnam. Welcome, madam. Today we gather our online webinar from their eminent speaker from Andhra Medical College. They are also interested to share their experience with all of us. Welcome, madam. Thank you, sir.
Thank you, Mr. President. Now I request Dr. Kannan, Secretary, ISA Pudukkottai, to offer the report. Kannan, you have to unmute.
Good evening, sir. Good evening to all. I am Dr. Kannan, Secretary, ISA Pudukkottai Branch. Successfully, we are conducting 10th webinar of second edition of Pudukkottai Bhudhan today. Today, our Pudukkottai Bhudhan webinar topic is Pediatric Anesthesia, Tracheo Esophageal Fistula. I welcome all our eminent speakers to the webinar. Last week, 19th March, our 9th webinar was conducted smoothly. The webinar topic was thyrotoxicosis, anesthesiologist perspective. This topic is our routine practical topic and the important one. We have divided the topic into 3 subtopics. First one is thyroid function test and its implications. Second one is perioperative assessment and optimization in thyrotoxicosis. Third one is anesthetic management of thyrotoxicosis for thyroid surgery. Our moderator was Dr. Sunanda Gupta, Professor Emeritus, Geetanjali Medical College and Hospital, Udaipur, Rajasthan. First subtopic, thyroid function and its tests, its implications, was done by Dr. Kanupriya Sharma, postgraduate, Geetanjali Medical College and Hospital. Dr. Kanupriya has explained the physiology of thyroid gland very well with perfect diagrams. She has shared the physiology of thyroid hormones with easily understandable flowcharts, because basis of the thyroid gland and its hormones and functions are very important to outcome the complications of thyroid abnormalities. She has nailed it by an excellent manner. She has elaborated the different thyroid function tests and its relevant implications to the topic. And then second subtopic is perioperative assessment and optimization in thyrotoxicosis. It was done by Dr. Seema Patani, Professor, Geetanjali Medical College and Hospital, Udaipur, Rajasthan. Any case, we have to rule out the complications before we take the case. Preoperative evaluation is very important to any kind of cases. Preoperative evaluation and optimization, which is very much important before take the case. Preoperative evaluation includes case history and detailed physical examinations and investigations with separate modes. Ma'am has explained all assessment relevant to the thyroid case in detailed manner, and ma'am has given special notes to the preoperative optimization of the patient for thyroid surgery. And the third subtype was anesthetic management of thyrotoxicosis for thyroid surgery, which was done by Dr. Alka Chabra, Professor and HOD, Geetanjali Medical College and Hospital. This was the core theme topic of our last webinar. Ma'am has explained the intraoperative management of complications which we expected in thyrotoxicosis with clear steps we have to follow. It was very much interesting in all practicing anesthesiologists, and ma'am has covered the detailed post-operative care also. Then the last webinar was attended by the increased number of 933 delegates. Thanks all your kind support. We need your kind support to continue the academic program smoothly. We ISA Pudukkottai very much thankful to our academic chairman Dr. Meenakshi sir. Thank you, sir. We are expecting the delegates to cross 1,000 in attendance in the upcoming webinars by our consistency and quality in our webinar. Thank you, sir. Thank you all.
Thank you, Secretary. Now it is my turn, the responsibility on my shoulders to introduce the whole team to the audience. Now, today we are having the participation by Andhra Medical College. That is for the second time. Some people last time, few people participated from Andhra Medical College. And today, the postgraduate, the youngest, Dr. Akhila Mummidi, she is going to talk about ISTPs. So Dr. Akhila is from Vizag. She was born in Vizag, grown in Vizag, and brought up in Vizag. So everything is Vizag only. I don't know where she got married. It is in Vizag or outside Vizag, I don't know. But she is good. She has graduated from Rangaraya Medical College, Kakinada, and presently pursuing MD in Andhra Medical College. And people used to hesitate to talk to her because she has participated in all debate shows, elocution competition, and she always won. So her spouse is keeping quiet, I was told, that he cannot open his mouth against her. So in addition to that, she is reading, gardening. She says gardening, but I don't know what gardening work she has done when she is doing anesthesia post-graduation. But her enthusiasm is to be appreciated, and we welcome Dr. Akhila for this show, and it will be followed by Dr. Preethi. She is assistant professor, but looking like a postgraduate of Andhra Medical College. So, madam is from GSL Medical College, Rajahmundry, MBBS, and she has come from Srikakulam, and she is working as an assistant professor in Andhra Medical College. And she is a CCLS instructor. As an anesthesiologist, she is interested in pain relief and critical care. See, nowadays, people interested in critical care, that too, a lady doctor interested in critical care is something surprising. It is just like a eighth wonder in the world. I don't know how she will cater to the critical care in times of stress, that it is very surprising that she is interested in critical care. And even though she looks like a postgraduate, her extracurricular activities are like Swamiji. She is interested in religious trips only. She is interested in religious trips, and she is touring. She is participating in religious events. That is also a surprising event from her. And the third person will be Dr. Venkata Krishnan, assistant professor. When she is religious, Dr. Preethi, Dr. Vaddi Preethi to be precise, she is religious, and he is a nuclear warfare man. He is trained in nuclear warfare. See, something I'm afraid, I'm frightening. These are the words I have never heard. That biological warfare. He is trained in biological warfare, and as a doctor, we have to protect the public from the bacterial and viral invasion. But he is trained in biological warfare, and he has conducted medical camps in Philippines and Indonesia. I don't know why he has not preferred India. Probably India, many people are catering, and he has gone overseas, and he has conducted camps in Philippines. And why he has conducted Philippines? He has served in Navy for 5 years. After 5 years of Navy service, he has joined Andhra Medical College. So he is a diplomat graduate, and he, in addition to that, he is a MBA graduate. But he is serving in the government medical college. He has conducted many ultrasound guided nerve block workshops, and she is an instructor for National Emergency Life Support. So he is having a variety of thing, and it is surprising to see from Andhra Medical College a person trained in Navy, nuclear warfare, biological warfare. I don't know what it is really. He has to give tips on that, what exactly he has been trained. And with this religious and nuclear warfare man, who can control them? I don't know really who can control them. So it is none other than Dr. Aparanji, Professor of Anesthesiology, Andhra Medical College. Madam, luckily we had you, or else it is very difficult to deal with these people. And Madam, as it is a pediatric webinar, Madam is smiling like a child. So that innocent smile is there. So we are very happy to invite the professor. See, now the PGs and the assistant professors are very casual, but professor is very nervous. So we are very happy. And Madam, in addition to Professor of Anesthesiology, she is the present ISA President, Vizag. She is a ISA President, Vizag. And from the school days, Madam is traveling. Madam is traveling everywhere, but not to the religious places, to all the places. Even Madam is in holiday moods. And it is happy to see Madam is traveling more often to Tamil Nadu. So I think she will be well versed in Tamil Nadu. So from Andhra Pradesh, a person traveling to Tamil Nadu, it is also nice. So we we welcome you. And as our secretary pointed out, 933 delegates have participated in the last event. We are aiming 1,000, but somewhere we are slipping. So I think this TEF webinar, with the support of Andhra Medical College, these four people will take us to the mark of 1,000. We will hope. Madam, I hand over the session to you, Madam. Please take it over. Thank you.
Good evening, Dr. Meenakshi, sir, for your long introduction. We are very happy to work with you, sir. You are one of the legendary in ISA. Congratulations, sir, for successfully conducting webinars with Association of Pudukkottai City Branch, which are very useful for postgraduates and DMB residents for academic purpose. We also congratulate the ISA Pudukkottai City Branch President Dr. Munian and Secretary Dr. Kannan for conducting these excellent webinars, which are very useful for not only students and for also practicing anesthesiologists. You will be shortly reaching your 1,000 marks, sir. And today our topics are based on pediatric anesthesia. Mainly we are concentrating, which is very important. Our PG, Dr. Akhila Mummidi, will speak on instrumentation, that is ASTPs, which we mostly use in pediatric anesthesia. And Dr. Preethi, she speaks about pre-anesthetic assessment of TEF. And our assistant professor, Dr. Venkata Krishnan, who is multi-talented, who speaks on anesthetic management of TEF. And regularly we encounter the cases of tracheoesophageal fistula. But each time we go for a case, each time it's challenging in posting the case and also in the recovery phase. So hope all the postgraduates will actively participate in the discussion, and all the questions will be taken in the end of the session, sir. Now we'll go over to Dr. Akhila Mummidi, who will speak on ISTPs.
Good evening, one and all. Thank you, ISA Pudukkottai and Dr. Meenakshi Sundaram sir, especially for the introduction. So I would continue with my topic. Today, my topic is ISTPs and its modifications. Going to the historical background, Ayre's TPs was described originally by Philip Ayre in 1937. It was introduced for endotracheal anesthesia of infants and young children undergoing cleft palate repair or intracranial surgeries. More than 80 years now, the modernized Ayre's TPs and its Jackson-Rees modification, that is Mapleson F, remain widely used in pediatric anesthesia despite significant advancements in anesthetic science and technology. The picture here is of Philip Ayre, who himself got repaired for cleft palate and cleft lip in his childhood. The original TPs comprised a T-tube with 3 limbs connected to the fresh gas supply, a 64 centimeter corrugated rubber tube, and a metal patient connector. It allowed fresh gas to be delivered to ET tube, allowing the anesthetist to be distanced from the operative field. Intermittent positive pressure ventilation could be performed by intermittently occluding the end of the corrugated reservoir tube. Here the picture shows the original TPs, where R stands for corrugated reservoir tube, P stands for patient connector, and F stands for fresh gas supply from anesthesia machine. Ayre's TPs or Mapleson E. So this Ayre's TPs belongs to Mapleson E classification of the breathing circuits. Its length is 5 centimeters and diameter is 1 centimeter. The parts consist of inlet, outlet, and a side tube. It is suited in neonates and infants in whom expiratory valve would have produced significant resistance. So, coming to the working of Ayre's TPs, in controlled ventilation, it is done by intermittently occluding the reservoir limb by thumb. So, neither air dilution nor rebreathing can even occur. Coming to the spontaneous breathing, in inspiration, since the peak inspiratory flow rates are higher than the fresh gas flow, gases are drained into the reservoir limb. If the reservoir limb capacity is less than the tidal volume of the patient, the air dilution occurs, converting the semi-closed system into semi-open system as per Collins classification. Collins classified the breathing circuits into semi-open or semi-closed depending upon whether the ambient atmosphere is allowed into the system, that is semi-open or open, or whether the system allows the fresh gas to be open into the ambient atmosphere, that is closed or semi-closed. Coming to the exhalation, both exhaled and fresh gas flow pass into the reservoir limb and then into the atmosphere. And expiratory pause. Fresh gas flow flushes out and fills the reservoir limb with fresh gases, pushing out the exhaled gases. If the reservoir limb capacity is more than the tidal volume of the patient and the fresh gas flow is less, then rebreathing definitely occurs. Harrison's modification of Ayre's TPs. Harrison reviewed modification of TPs in relation to the capacity of the reservoir, that is expiratory limb, and classified the Ayre's TPs into 3 categories. Type 1, where there is no expiratory limb as seen in the first figure. Type 2, where the volume of expiratory limb is greater than the patient's tidal volume as seen in the second figure. Type 3, volume of the expiratory limb is lesser than the patient's tidal volume as seen in the third figure. He concluded that the most useful was type 2. Mapleson E or Ayre's TPs, the factors to be considered for spontaneous breathing are: the diameter of the reservoir must be sufficient to have lowest possible resistance. Volume of reservoir limb should not be less than the patient's tidal volume. What happens if the reservoir limb is equal to tidal volume? Then the fresh gas flow should be increased 2.5 times the minute ventilation to prevent air dilution. If the reservoir volume is less than the tidal volume, then fresh gas flow has to be increased further. Otherwise, the air dilution will definitely occur. If the reservoir limb is 0, that is, there is no expiratory limb, then the fresh gas flow should at least be equal to the peak inspiratory flow rate of the patient to prevent air dilution. So what are the advantages and disadvantages of this Mapleson E or the Ayre's TPs? The system has very low resistance, very minimal dead space, and there are no valves throughout the circuit, so it is easy to use. Disadvantages: there is no feel of the bag, no APL wall, so no pressure buffering effect of the bag, and there is no special scavenging system. Coming to the Jackson-Rees modification of Ayre's TPs, that is Mapleson F, It connects a two-ended bag to the expiratory limb of the circuit where the gas is escaping via the tail of the bag. The release of gas from the distal end of the bag can be controlled by partial or complete occlusion by the operator. This allows positive and expiratory pressure in spontaneously breathing patients and intermittent positive pressure in apneic patients. Similar effect by addition of backtail valve, which delivers an adjustable resistance to gas flow and maintains partial inflation of the bag. So this Jackson-Rees modification of Ayre's TPs is specially used in neonates, infants, and pediatric patients less than 20 kg in weight or less than 5 years of age. Coming to the functional analysis, for spontaneous respiration, the relief mechanism of the bag is left fully open. Small movements of the bag demonstrate the pattern and the rate of breathing. The flows required to prevent rebreathing during spontaneous respiration are 2 to 3 times the minute ventilation. For controlled respiration in inspiration, the hole in the bag can be occluded partially or completely during inspiration, and ventilation is done by squeezing the bag. In expiration, the open end is released to allow the gas in the system to escape. So the flow required for controlled respiration is about 1.5 times the minute ventilation. So what are the advantages of Jackson-Rees modification? It is also valveless. It is having very low resistance, and at appropriate flow rates, there is very minimal dead space. The reservoir bag serves as a useful visual and tactile indicator of the respiratory effort. It is also easy to apply high pressure rapidly if needed. It is lightweight and economical. It is effective for both controlled and spontaneous ventilation. Disadvantages. So to avoid rebreathing, high fresh gas flows are needed to that of the patient's minute ventilation. So because of the high fresh gas flows, there is large amount of volatile agent that has to be needed, and so a major source of theater pollution. Barotrauma is another disadvantage. That is, occlusion of the relief valve can increase airway pressure, producing barotrauma. In the figure here, when there is low fresh gas flow, the reservoir bag is majority filled with alveolar gas with CO2. And it is not replaced with the fresh gas. Whereas, when there is high fresh gas flow, the reservoir bag filled with CO2 is replaced with the fresh gas with O2, and the patient majority inspires the fresh gas with O2. So in conclusion, the modified Ayre's TPs remains essential in pediatric anesthesia despite its limitations. While the pediatric circle system is preferred in many cases, the TPs is ideal for neonates, low lung compliance, and settings without an anesthesia machine. It is portable, reliable, and non-electronic, easily connecting to various oxygen sources. Experienced anesthetists value its tactile feedback, allowing to be better control over lung inflation and inflation. The TPs remains indispensable in specific clinical scenarios, making its mastery a crucial skill for anesthetists. Thank you.
Thank you, Akhila, for your presentation. We will take questions at the end of the session. If there are any questions, please post them in the box. We will go over to our next speaker, Dr. Vaddi Preethi, Assistant Professor of Anesthesia, Andhra Medical College. She will talk about preoperative preparation of a unit with tracheoesophageal fistula. Over to Preethi.
Very good evening to one and all. Very good evening to one and all. Thank you, Dr. Meenakshi Sundaram sir, for providing me this opportunity to speak on this online platform. Today, I'm going to discuss about pre-anesthetic assessment of tracheoesophageal fistula. So what is tracheoesophageal fistula? It is nothing but an abnormal communication between the trachea and the esophagus. So when does these babies present to us? So they generally present to us during the first week of neonatal life. And why is it important? Why we are dealing with all this tracheoesophageal fistula is because it imposes many challenges to the anesthesiologist in view of prematurity, associated anomalies, and also physiological derangements in the cardiac and respiratory system. So my objectives for today's discussion is about history. We'll deal with incidence and etiology, a small note on embryology, classification, and associated anomalies. What is the pathophysiology of tracheoesophageal fistula? How do we diagnose? What is the treatment modalities available? And how do you evaluate the baby preoperatively? Coming to the history, the first description of esophageal atresia is done by Thurston in 1670, followed by the first plan of management is by Richer in 1913. And the first to achieve long-term survival by Ladd and Bevan with the help of a staged approach in 1939. The first successful primary repair was done by Hyde in 1941. The instance is around 1 in 3,000 to 4,000 live births, which indicates that this is one of the most commonest anomaly among the pediatric population. And there is a slight male predominance when compared to the females, and most of the infants are premature and they are very small for gestational age. So this is very important while you are evaluating the baby. You have to ask whether the baby is preterm or term, because it is one of the most important prognostic indicator which determines the mortality of the baby. Esophageal atresia is more common in twin pregnancy compared to a singleton pregnancy. The underlying etiology remains unknown, but it is mainly because of a combination of genetic, epigenetic, and environmental factors. A small note on embryology. So what happens during, why this trachea and esophagus are only involved in the development of fistula? Because they share a common origin from the foregut. There are 4 sequential processes which are involved in the development of fistula. One is anterior and posterior patterning, which helps in delineating the primitive gut into foregut, midgut, and hindgut. And the dorsal and ventral patterning, which helps in delineating the anterior foregut into trachea as well as esophagus. Later, these two will get separated, they elongate, and then maturate by increasing in their diameter. As you can see here in the pictorial diagram, you have at the age of 22 to 23 days of gestation, corresponding to embryonic day 9.5, there is a development of ventral diverticulum from the foregut, which is nothing but a respiratory primordium. This respiratory primordium will gradually elongate and it starts splitting. After that, it will widen in diameter, which undergoes maturation into trachea. And the other part of the foregut will remain as esophagus. This is a theory which is postulated during 2019 as splitting and extension model. There are many theories which has been implicated in the embryogenesis. One is outgrowth model, the other one is watershed. You have a septation model and a splitting and extension model. In an outgrowth model, where in the upper picture, you can see this is an outgrowth model where from the foregut, there is a evagination of the trachea, which undergoes a caudal elongation and then it splits into lungwards. The other part of the foregut will remain as a esophagus. Whereas in watershed, it divides into 2 tubes from the initial point and then they grow caudally. Whereas in septation model, there is a cranial elongation of the trachea until the pharynx, and then it will form a septum, dividing the foregut into trachea as well as the esophagus. Some studies have conducted on mouse models, and they have delineated the cellular events that are occurring during the development of trachea as well as the esophagus, where they have seen an expression of ventral, which represents the tracheal part, the NKX2.1 epithelium, and the dorsal SOX2 part of the esophagus, that is dorsal part. These two will undergo a medial constriction at the midline. Then later, it will constrict, later forming a septum. Then the septum will get remodulated, and there is a invasion of the mesenchyme at this part, delineating into 2 distinct tubes, that is trachea as well as the esophagus. So these are the genes that are involved in the formation of the trachea and esophagus. There are many signaling pathways which are involved. One of them is Hitchcock expression. There is also BNP, WNT ligands, and thyroid transcription factors which are involved for the formation of trachea and the esophagus. Classification. The original classification system was first described at Oak in 1929, redeveloped by Ladd in 1948, and revised by Cross in 1953. this remains the most predominant system in use today. So in the most commonly used classification is gross. This gross has divided into five groups from A to E. In gross A, he included the esophageal atresia without any fistula. That is, you can see in the picture here, you have an upper blind pouch and the lower blind pouch of the esophagus that is above the level of the diaphragm. There is no connection between the trachea and the esophagus. This is also called as long gap esophageal atresia, and the incidence is around 6%. Coming to the gross B, there is an esophageal atresia, that is, the baby is having atresia or some part of the esophagus is lacking and it is having a communication with the trachea. The fistulous connection can be seen here in the third picture in the right side of the diagram, where the upper pouch is being connected to the esophagus. And the most commonest one is the gross C classification, which accounts for 85% of the population. It includes esophageal atresia with a distal fistula. In the fourth picture, you can see is a gross C, where the upper blind pouch is normal and the distal band is being connected to the trachea at this level. The other one is your gross D, which accounts only 1% of the population having an esophageal fistula with proximal and distal connection. So you can see here, we have both connections. The upper part as well as the lower part is being connected to the trachea. The last one is H-type tracheoesophageal fistula. Here, there is no esophageal atresia. That means you have a continuation of the esophagus, but it is being connected to the trachea at one particular point. So it is like a H. So it is called as H-type tracheoesophageal fistula, which is accounting for 4% of the population. And Kul is the one in 1976. He has demonstrated 96 malformations during the development of trachea as well as the esophagus. And he has developed a name called Atlas of Esophageal Atresia. And all these malformations has been categorized into 10 groups from type 1 to type 10, where he included esophageal stenosis, laryngeal stenosis or tracheal stenosis, and laryngotracheal esophageal clefts also. There is another classification which is first described, that is by what? It categorizes into 4 subtypes. Type 1, which is nothing but an obliteration of the esophagus. Type 2 is atresia without the fistula. Type 3A, it has 3 subtypes, A, B, and C, corresponding to atresia with proximal fistula, atresia with distal fistula, and atresia with proximal and distal fistula respectively. In type 4, you have only H type of fistula. When comparing the gross and mode classification, gross A to E will be equal to type 2 to type 4 in the mode classification. Coming to the associated anomalies. Here you can see that there is monogenic syndrome. That is nothing but involvement of defective gene in only one form. I already told in the cellular events that SOX2, which is the dorsal part, which is forming the esophagus, if it is defective, they have confirmed the clinical relationship with the mouse model and found that there is a 100% tracheoesophageal frequency that is being occurred in case of AEG syndrome, which comprises of anophthalmia, esophageal atresia with or without fistula, and urogenital abnormalities. And the other one is DJOT syndrome, having a defective gene in TBX1, having a frequency of 33%. And the mouse model also confirmed the frequency. And there are other abnormalities like alveolar capillary dysplasia and Pallister-Hall syndrome, where the babies will have polydactyly and an association with bacterial anomalies. And it has a frequency of less than 1%. There are chromosomal duplications, and generally in pregnant patients, we can see these abnormalities like trisomy 18, 21, and 30. Among these 3, trisomy 18 is the one which is having a highest frequency compared to 21 and 30. That is around 25%. But there is no that clinical correlation between the frequency as well as the comparison with mouse model. The other unknown and multiple mutations, which is most commonly involved, is Bacterial syndrome. This is nothing but a constellation of many anomalies. And it has a frequency of 50 to 80%. And they have found the relationship in a adriomycin mouse model, where there is a correlation of around 45%. So now we'll deal with bacterial anomalies. The bacterial anomalies, as the name, it has a V stands for vertebral, A for anus, C for cardiac, TE for tracheoesophageal, and R for renal, and L for limb. Previously it was Vater. Now they have included both cardiac as well as limb anomalies. As you can see in the picture, the cardiac defects corresponds to 35%. So majority of the patients with tracheoesophageal fistula have cardiac defects. followed by vertebral anomalies, and followed by genitourinary anomalies. Why these vascular anomalies are needed? Because it is associated with many changes in the babies, and preoperatively, based on the defects the babies are having, you should advise the investigations. Coming to vertebral defects, the most common vertebral defects which are seen in tracheoesophageal fistula babies are scoliosis, rib deformities, sacral agenesis. In anorectal malformations, imperforate anus is most common. In cardiovascular defects, which is the most commonest one, which is occurring in tracheoesophageal fistula, include ventricular septal defect. Other than that, the second most common is tetralogy of Fallot, patent ductus arteriosus, atrial septal defect. Why is it needed? Generally, during the preoperative period, we have to go for echocardiogram to rule out the ductal lesions. Here we have duct-dependent lesions and duct-independent lesions. In duct-dependent lesions, we have to maintain those patency. Otherwise, the baby will land up in desaturation and other comorbid conditions. And the other thing is, we should always look for right-sided aortic-ash. Why is this important? Because most of the tracheoesophageal fistulas are approached through right side. But if the baby is having right-sided aortic-ash, the approach has to be from the left side. Because of that, we have to go for echo and we have to check all these cardiac anomalies. Coming to renal anomalies, it includes Potter syndrome, horseshoe kidney, and polycystic kidney. Lip anomalies are mostly radial dysplasia, absent radius, syndactyly, and polydactyly. And the most common cause of mortality, which is observed in this tracheoesophageal fistula, is because of cardiovascular defects. And all these anomalies are most common in D type rather than H type of tracheoesophageal fistula. Coming to the pathophysiology, there are two things which are observed. One is dehydration in the fetus, the other one is aspiration pneumonia. Why dehydration is seen? Dehydration is seen because as the baby is unable to swallow the amniotic fluid that is present within the womb, the baby is not absorbing any water from the amniotic fluid. Because of that, the baby will be having dehydration. After the delivery of the baby will not have proper oral feeds. Because of it, we can observe dehydration in the fetus also. Second thing is aspiration pneumonia. Why this aspiration pneumonia occurs? Aspiration pneumonia occurs because of excessive oral secretion or spillage of gastric contents from the blind pouch of esophagus into the trachea. Not only aspiration pneumonia, you can also observe abdominal distension and scaphoid. Why this is seen? As you can see in the P picture, the trachea is being connected to the esophagus. Whenever the baby is inspiring, some amount of air will be leaked into the esophagus and then it will enter into the stomach. But when compared to spontaneously breathing patient, this is more common in ventilated. So, most of the babies avoid bag and mask ventilation. Otherwise, you will create increased abdominal distension, ultimately leading to rupture of the stomach and creation of the pneumoperitoneum. And in this scaphoid abdomen is seen in pure esophageal atresia. That is, it is not having any connection with the trachea, because of which there is no air entering into the stomach, leading to a scaphoid abdomen. Fistula location is also very important for us. Most of the patients, around 61% of the population will have a mid-tracheal location of fistula. In 33%, it is just above the carina. In 8% of patients, it is cervical. In 1%, it is bronchial. More than one fistula is seen in 3% of patients. In H type of fistula, the fistula is typically located in the cervical region. Why is it important? Because while repairing this H type of fistula, the surgeon will approach through the cervical area. Whereas in esophageal fistula, atresia without a fistula, it is usually 1 to 2 centimeters from the blind ending upper pouch. Coming to the below diagram, you can see the red line which determines the flow of feeds and the blue line which determines the flow of air. As I already described in the previous slide, how the babies will be presented. So in case of type A and type B, as you can see here, there is a spillage of contents from the upper esophagus into the trachea. So these babies will be presented with aspiration. In case of type B also, as they are having a fistula connection, the aspiration will occur. The contents of the esophagus will be entering into the trachea, leading to aspiration. In type C, you have both abdominal distension as well as aspiration. Similarly, in type D and E also, you will observe. Coming to the clinical presentation, as the baby is unable to swallow the saliva, it will start frothing out. So you will see frothing and bubbling at the mouth as well as at the nose. There is a 3C presentation. One is coughing, choking, and cyanosis. And the baby may also present with respiratory distress because of aspiration. If the baby is fed, these symptoms will be exacerbated, causing regurgitation as well as aspiration, ultimately leading to respiratory distress syndrome and atelectasis. One thing is already the babies may be a premature babies having a lung immaturity. So they may also have a respiratory distress syndrome. Upon this will aggravate the condition. Other condition is esophageal atresia with a distal tracheoesophageal fistula. When they will appear and what are the clinical presentation of these cases. Esophageal atresia with a distal tracheoesophageal fistula, the babies will appear early in life because it will be easily diagnosed and they may present with damaging pneumonitis and abdominal distension. Whereas in case of esophageal atresia in case of tracheoesophageal fistula, that is H type, they may be misdiagnosed because there is no coiling, the baby can feed easily, but they present later in life, and they also present with refractory bronchospasm and recurrent pneumonitis. How do you diagnose this tracheoesophageal fistula? Antenatally, we can diagnose by the triad. It will confirm the esophageal atresia. One, you will see polyhydramnios because as the baby is unable to swallow the amniotic fluid, more amount of fluid will be present in the mother. So polyhydramnios. The second is small or absent fetal stomach bubble and the dilated upper esophageal pouch. Postnatally, how do you assess? So when you see the symptoms, the clinical features which are described, if you are seeing all these type of features, you should always suspect esophageal atresia or the tracheoesophageal fistula. Then you have to advance the oral nasogastric tube. If there is a failure to advance this naso or oral gastric tube beyond 10 centimeters from the mouth, is highly suggestive of esophageal atresia. Then you have to order for a chest X-ray or an abdominal X-ray. Here are the two images which shown here. You can see the coiled tube in the upper part in both the cases, whereas in the abdomen, you are seeing a air distended stomach in the upper image and there is no air distension in the lower image. So what it means? As I already told, in a H type of fistula, where there is a connection between the trachea and the distal part of the esophagus, the amount of air the baby is inspiring will be reaching the stomach. So the stomach will be distended enough. So it represents that fistula is present in this case. If there is no air distension stomach, you can see that the baby is having only esophageal atresia without any tracheoesophageal fistula. And if the baby presents later in life with aspiration features, you can see diffuse infiltrates on the chest X-ray. There are many studies which are conducted by Kasif et al. One of the studies, a dynamic esophagus patency assessment. They have done in 132 fetus and he have categorized into 3 groups. One is the test is normal, abnormal or undetermined. And he has compared all these tests with the postnatal findings and they have found that the detection rate was 100% for esophageal atresia. What about the contrast studies? Whether we have to go or not? Contrast studies are generally contraindicated because of chemical pneumonitis. Now they are using water-soluble contrast in order to prevent that chemical pneumonitis. If at all, if you want to use barium, only 1 to 2 ml has to be given and you have to take a serial X-rays to see the spillage of this barium into the tracheum. And it is correctly diagnosed with multi-detector row CT esophagography. And now the MRI has been become useful. It is improving the diagnostic accuracy, but compared to the ultrasound, the predictive value is only 44%. And here you can see in the below images that in a patient with esophageal fistula, there is absent stomach bubble. In the right side of the diagram, you can see a upper dilated esophageal pouch, which is called as pouch sign. And you have a silver lining of amniotic fluid in the stomach. So this determines the baby is having a tracheoesophageal fistula with atresia. So what are the treatment modalities we have? In the treatment modalities, the definitive treatment is always a surgery. The detailed description of it will be discussed by the next speaker. And you can wait up to 12 to 24 hours period for full stabilization of the baby, full assessment of the baby, and then you can proceed for the surgery. But if the infant who is in respiratory extremes, you have to do 2 things. One, you can do on the bedside. The other thing, you have to send the baby for the operative theatre. One is open gastrostomy tube, where you have to insert 10 French to 12 French Malicot placed at the bedside to decompress the gastrointestinal tract. The other one is to place a vessel loop around the gastroesophageal junction, which helps in stabilizing the patients. Next, in case of long gap esophageal atresia, that is only esophageal atresia, you have an upper blind pouch and a lower blind pouch. In those cases, first the baby should be managed by feeding gastrostomy because there is no tract for the baby to feed. So you have to create a gastrostomy in order to feed, and later you have to go for delayed primary anastomosis. It may take up to 4 to 6 weeks. Based on the X-ray, you have to determine the difference between the upper and the lower esophagus. Depending on it, you can go for anastomosis or esophageal replacement. And most importantly, before proceeding with the surgery, always look for the physical condition of the neonate, whether he is stable or unstable. Depending on that only, you have to go for surgery. In one study conducted, they have found that up to 3 days to 2 weeks of birth, they have delayed the operation. But more than 2 weeks, they should not be delayed. Otherwise, there is a chance of aspiration pneumonia, increased chance of aspiration pneumonia, and also development of free fistulas. And in case of minor H defects, which I told that it is mostly undiagnosed and they are asymptomatic. So in one case, it has been delayed from 26 days to 4 years also. So now we will deal with pre-anesthetic evaluation, which is our important topic. So you have to take the history as well as physical examination. In a history, what should be taken? First, you have to give importance to the weight of the baby as well as whether the baby is term or a preterm, because these are the two which indicate the mortality rate and survival rate of the babies. So always these two has to be taken care, and you have to ask for the mode of delivery and also the events that occur during the pregnancy, whether the patient is having a twin pregnancy or polyhydramnios, any type of infections, maternal diabetes or hypertension, all these have an increased risk of tracheoesophageal fistula. And we should also ask for anesthetic reactions in the family. Look for feeding history, which gives a features suggestive of aspiration. Look for hydration, and always observe for congenital anomalies, which I discussed previously about the bacterial anomalies. So look for all these anomalies. If you have suspicion of any anomaly, you should always go for investigations. And history of polyhydramnios will always suggest the baby is having renal anomalies also. Coming to the investigations, routine investigations has to be done. Apart from that, you have to go for electrolytes and ABG, because most of the babies with aspiration pneumonia can land up in sepsis also. And because of improper feeds, the baby may have electrolyte disturbances. So always look for serum electrolytes and ABG. And as the baby will be, most of the infants are neonates, preterm infants, there is a more chance for hypoglycemia and hypocalcemia because of immaturity in the organs. Always advise for chest X-ray, abdominal X-ray, and renal ultrasound. The most important among all these investigations is your echo, which we have to do for, you have to look for right-sided aortic arch, because it is most commonly seen in 2.5% of cases, and it signifies a higher mortality, and the approach will be from the left thoracotomy. Apart from that, you have to look for duct-dependent and non-duct-dependent lesions also. If there is a duct-dependent lesions, you have to wait before proceeding the surgery. And look for preoperative saturations, because the lung components will be affected. One, because of gastric distension, there is an elevation of the diaphragm by the H type of fistula, causing basal atelectasis. Because of prematurity, there is a decreased lung components. All this will, and if there is a larger fistula, the more amount of air will be entering into the stomach rather than the lungs. So oxygenation of the lungs will be defective. So always look for preoperative saturations. So always, as the most important systems in us is cardiac as well as respiratory. These two systems should be handled carefully. So in tracheoesophageal fistula, as the respiratory status is very dependent, we have to optimize the respiratory status first. Babies may need simple oxygen supplementation to a CPAP, and some babies with severe pneumonia may also land up in intubation and ventilation. While after intubation of the baby, so where should you keep the endotracheal tube? Generally, in the descriptions, the endotracheal tube has to be placed below the fistula and above the carina in order to look for bilateral air entry and adequate ventilation. We don't know whether we have kept below the fistula or not. So you have to monitor the gastric inflation. If the stomach is inflating much, it determines that we have placed the endotracheal tube at the level of fistula. So we have to adjust the tube accordingly. And minimal pressure settings has to be kept on the ventilator, because it helps us to decrease the peak pressures as well as the plateau pressures of the lung because of decreased lung compliance. Coming to the prognostic classification of esophageal atresia, tracheoesophageal fistula, this will help us in guiding the risk stratification of the babies. We have 3 classifications, which is proposed from 1962 to 2009. First one is Waterston, which has proposed in 1962. He has taken 3 determinants. One is birth weight, one is anomaly, as well as presence of pneumonia. If the birth weight is around more than 2.5 kgs and without any anomaly, the survival rate is good, that is around 97%. Whereas in case of P, if the birth weight is more than 2.5 kgs with the presence of pneumonia and mild to moderate congenital anomaly, the survival rate has been decreased to 59%. In case of category C, taking the birth weight criteria as 1.8 to 2.5 kgs, there is severe pneumonia and severe congenital anomaly. So the survival rate has been further decreased. In Spitz classification that is provided in 1994, he has categorized into 3 groups, 1, 2, and 3, based on birth weight, and he has taken only cardiac anomalies without any pneumonia, because he has seen major cardiac anomalies were seen rather than pneumonia. So in first category, the birth weight is around more than or equal to 1.5 kg without any cardiac anomalies, or more than 1.5 kg with major cardiac anomalies, and less than 1.5 kg with no cardiac anomalies. All these have a decrease in the survival rate gradually. In 2009, this Okamoto has taken the same category like Spitz, but he has modified the birth weight to 2 kg. Babies weighing more than or equal to 2 kg without any cardiac anomaly have a survival rate of 100%, and with major cardiac anomaly, the survival rate has been further decreased. In case of less than 2 kg without any cardiac anomalies, the survival rate is good enough compared to less than 2 kg with major cardiac anomalies. Waterston classification also helps us to not only stratify, but also helps in planning the timing of surgery. In case of Waterston A classification, the babies can undergo surgery. They can proceed for surgery because there are no anomalies associated in this A category. But in case of B category, the babies are having pneumonia as well as some sort of congenital anomalies. So before proceeding for the surgery, they have to be stabilized first. There is short-term delay can be accepted. But in case of C category, the babies who are weighing less than 1800 grams or presence of severe pneumonia or congenital anomaly, they require staged repair because they cannot tolerate the anesthesia as well as the surgical methods. Coming to major anesthetic issues that are present. First one is evaluate for aspiration pneumonia, dehydration, and hypoglycemia. If you know the major anesthetic issue, we will take the measures to prevent all these before proceeding for the surgery. Second one is over distension of the stomach from entry of air directly in the stomach below the fistula, or inability to ventilate the child because of large size of fistula. The problems associated with other anomalies, particularly patent ductus arteriosus, has to be ruled out, and other forms of associated congenital anomalies has to be seen. Along with other babies, tracheoesophageal baby is also will be having a difficult cannulation situation, difficult intubation because of associated congenital anomalies, and there is a high chance of hypoxemia, hypothermia, hypoglycemia, and hypocalcemia. And there is a need for postoperative intensive care leave. So how do you manage? To prevent aspiration pneumonia, the first step is to keep the baby nil level. So stop all the enteral feeds. Next, the baby should be nursed in prone and a head-up position, sitting or lateral. Among all these positions, the head-up position is widely accepted. Coming to the fluids, to avoid dehydration and hypoglycemia, always proceed with isotonic saline or 5% dextrose with 1/4 of normal saline. To prevent respiratory infections, we have to give prophylactic antibiotics, either an ampicillin or a gentamicin. Vitamin K is all needed for all the type of babies, and less than 1.5 kgs, we have to give compulsorily. The upper esophageal pouch should be cleared by continuous suction applied with the help of Replog tube or repeated suctioning of the upper pouch. This Replog tube has 2 lumens, outer lumen and an inner lumen. Outer lumen should be connected to a low suction pressure because the baby has a very less amount of acceptance to the pressure. So the pressure has to be reduced, and the repeated suctioning can be done in order to prevent the aspiration further. And neonates are at a high risk of gastric distension. So in those cases, when the baby are present in the neonatal ICU care, you have to treat them with emergency needle decompression, or you can go with gastrostomy placement also. In duct-dependent lesion, continue PGE1 infusion to maintain the patency. And if baby stabilizes only, then only you have to proceed for the surgery. And in some cases of neonates, you should go for TPM because most of the babies will be in NVM for many weeks until they have been stabilized. So there is an option for TPM based on the gestation age and weight of the baby, you can go. A small note on preoperative bronchoscopy. At the time of anesthesia induction, many surgeons advocate rigid bronchoscopy. Why? Because many times we can't assess the presence of fistula. So to define the site of entry of distal tracheoesophageal fistula, we have to go for preoperative bronchoscopy and also to look for unrecognized anomalies such as upper pouch fistula and also to know the degree of tracheomalacia. Whereas in case of pure atresia, we don't suspect that there is a connection between the trachea and the esophagus, but there are more than 4% reported cases of fistula. So in pure esophageal atresia also, as the instance of upper pouch fistula is more, you have to go for preoperative bronchoscopy. Take home message, the knowledge and ability to anticipate the challenge in managing these patients plays a vital role in the final outcome. Prematurity and associated congenital heart disease, these are the major contributors in the mortality. Managing TEF requires a well-coordinated interprofessional team to ensure a complete care and optimal outcomes. The collaborative approach to TEF management ensures that all aspects of patient condition should be addressed, from diagnosis, surgery, to post-operative care and long-term follow-up. This will help in improving the overall prognosis and quality of life of the children. These are my references. Thank you.
Thank you, Preethi, for extensive presentation. Presentation is very good and your slides are very much informative. Any questions we will be taking at the end of the session, meanwhile you can post in the chat box. Let us go for our next presentation, that is of Dr. Venkata Krishnan. He will be talking about anesthetic management of esophageal fistula in continuation to Dr. Over to Dr. Venkata Krishnan.
Thank you, ma'am. Good evening, one and all. Thank you, Dr. Aparanji, ma'am. Thank you, Dr. Meenakshi Sundaram, sir, for giving this opportunity. My topic is tracheoesophageal fistula anesthetic management. So I will cover this topic in following heads. Treatment options available: pre-op risk stratification, preoperative preparation, preoperative bronchoscopy, anesthetic considerations, anesthetic management, post-operative complications, and summary. So surgery is the definitive treatment for esophageal atresia and tracheoesophageal fistula. The surgery, tracheoesophageal fistula repair is urgent, but it is not an emergent. Usually it is performed in 24 to 72 hours after the stabilization of the neonate. Delay in surgical correction increases the risk of the aspiration pneumonia. So the treatment options available are: one is patient can undergo a palliative procedure. If the patient is too sick and gastric distension is there, patient can undergo palliative procedure like gastrostomy, or patient can undergo primary repair or stage correction. Generally, C type of fistula will undergo primary repairs using the right thoracotomy or thoracoscopic approach. In the first step, isolation and ligation of the fistula, followed by mobilization and anastomosis of the esophagus will be carried out. Staged correction, especially done in infants with who are unstable, sick, and infant is having severe pneumonia. In these cases, the infant will go for the staged correction. In staged correction, initially, child will undergo primary esophagostomy or gastrostomy, and followed by, in the second stage, correction of esophagus atresia 3 to 4 months later. Usually, it is done in cases of esophageal atresia without fistula. So, open thoracotomy approach, it is a technique of choice in developing countries because the facilities and training for the thoracoscopy procedures is not available in all the developing countries. So, it is a technique of choice in developing countries. The approach is right thoracotomy approach unless the patient is having the right-sided aortic arch. If the patient is having, as earlier speaker mentioned, 2.5% cases patient will have right-sided aortic arch, in which the technique of choice is from the left thoracotomy. If the fistula is at the level of the carina, one lung ventilation may be required, and we have to secure the endobronchial tube and have to do the one lung ventilation. The other technique is thoracoscopic approach. Thoracoscopic approach is minimally invasive, but the problem with the thoracoscopic approach is it can cause, we have to create the pneumothorax that can create the direct compression of the vascular structures and impairment of the ventilation. It can cause the compression over the inferior vena cava that results in the desaturation, and also CO2 retention results in hypercarbia and acidosis. If the child is too sick, these infants cannot tolerate thoracoscopic approach. Preoperative risk stratification. Preoperative risk stratification will be done by 3 scales as detailed discussion has been carried out by earlier speaker. One is Waterston classification 1962. It's based on the birth weight, congenital anomalies, associated congenital anomalies, and presence of pneumonia. And speech classification 1994. It is based on the birth weight and congenital presence or absence of congenital anomalies. And third class scale is Okamoto's classification. It is introduced. It is the latest scale. It is introduced in 2009. It's based on the presence birth weight. If the infant birth weight is more than 2000 grams, we can safely take it up for the surgery. The preoperative preparation, we have to carefully take the several steps, and we have to correct the dehydration. We have to correct the electrolyte imbalance if anything is present. We have to correct the hypoglycemia, and we have to prevent the hypothermia. Good antibiotic prophylaxis has to be given to prevent the pneumonia and to prevent the sepsis. The child is to be nursed in the prone position with an nasogastric tube in place, and all required investigations are to be carried out like CBC, chest X-ray, especially 2D echo has to be done to check whether any right-sided aortic arch is there or not, or any associated congenital anomalies are there or not. So preoperative preparation, certain interventions have to be done to protect the lungs from the aspiration by avoiding the enteral feeding of the infant, by keeping the infant in the upright position so that aspiration can be prevented, and intermittent suctioning of the upper pouch, antibiotic administration for the management of sepsis and aspiration pneumonia, and gastrostomy also can be performed. If the stomach is over distended and it is impairing the ventilation. Gastrostomy may be done in the preoperative period to prevent the gastric distension and rupture of the stomach, and it improves the ventilation and venous return, and also it helps to prevent the reflux of the gastric content into the lungs. It allows the proper nutrition of the baby in the pre as well as in the post-operative periods. Gastrostomy is basically palliative procedure. Preoperative bronchoscopy is not routinely indicated in all institutions. It can be done for the better planning and anesthetic management, but it depends from the institute to institute. If you perform the preoperative bronchoscopy, we can perform it through the inhalational induction, and we can do the rigid bronchoscopy, and we can define the fistula location, and we can determine the unusual characteristics of the fistula, like presence of double fistula or triple fistula or any fistula nearer to the carina. We can easily diagnose, and we can plan the surgical as well as anesthetic management. And also we can diagnose the presence of any tracheobronchitis is there or not with the help of the rigid bronchoscopy in the preoperative period. Anesthetic considerations. Main anesthetic issues in the anesthetizing the tracheoesophageal fistula. Ineffective ventilation due to presence of the large fistula, especially if the fistula size is more than 2 or 3 centimeters, there will be air leak and inadequate ventilation will be there. And it can cause the massive gastric distension that can again push the diaphragm upward and causes the compression of the lungs and can result in the ineffective ventilation. Pre-existing lung pathology may be there as these infants are premature. Infant may be having the lung pathology and also can be from the aspiration pneumonia. And also these premature infants can have the respiratory distress. Sometimes child may have the apneic spells. Even while maintaining the anesthesia also, we have to be very careful that we should not give the more narcotics. If you administer the more doses of opioids and narcotics, infant may go into the apneic spells in the postoperative period. So we have to be very careful. We have to give the drugs in titrated doses, and we have to be consider all the associated any associated congenital cardiac anomalies are there, any right-sided aortic arch is there, any congenital associated anomalies are there. We have to plan for the management of that. And anesthetic management involves proper ventilation of the lungs and maintenance of the hemodynamic stability in the intraoperative period, avoidance of hypothermia in the intra and as well as the postoperative periods, and we have to carry out the thorough suctioning of the upper pouch and adequate pre-oxygenation we have to do. So these are the monitoring equipment which are required in the operation theater. ECG, non-invasive blood pressure cuff, end-tidal carbon dioxide, temperature probe, pulse oximeter. Especially if the patient is having ductal dependent cardiac lesion, we have to put the 2 pulse oximeters ready, one for the preductal, one for the postductal. And we have to keep the precardial stethoscope. This precardial stethoscope is to be fixed in the, especially in the left axilla. It helps to detect the adequacy of ventilation also, as we keep the child in the right lateral position. So operation theater readiness, we have to keep at least 2 peripheral IV lines, good flowing IV lines. We have to keep for the resuscitation, as infant may go into the hypotension and we may have to resuscitate. So we have to have good 2 peripheral IV lines. Cross-matched blood is to be kept ready. Central venous access is not routinely recommended. Central venous access is recommended especially in if we anticipate prolonged postoperative parenteral nutrition and the child is very sick, we may require prolonged antibiotic therapy. In those cases, central venous access may be required. And we have to keep the operation room as well as the child warm by using the fluid warmers and as well as forced air warmers. We can keep the child euthermic. Coming to the airway management, awake intubation without muscle relaxation is a standard procedure, but this technique may differ from institute to institute. But as per the description of the different textbooks, it is a standard procedure, as it is safe and ventilation is maintained, and we can avoid the positive pressure ventilation, and we can safely secure the airway. That is why reason it is a standard procedure. But the problem with the awake intubation is, if the infant is a premature, this awake intubation can result in the rise in intracranial pressure, and it can result in intraventricular hemorrhage. So we have to be, if the premature infant, we have to take precautions to maintain the adequate depth by using inhalational agent, something like that. Ensure the adequate ventilation after the intubation. If the ventilation is inadequate, so the reasons can be larger tracheoesophageal fistula, as discussed earlier. It is more than 3 cm or 2 cm, and fistula nearer to the carina also, there will be a volume loss and inadequate ventilation. So how to confirm the endotracheal tube? Good position of the endotracheal tube is by auscultation of breath sounds. Especially what we do is, directly we go into the endobronchial and we slightly withdraw and auscultate both the lungs. If the air entry is equal in both the lungs, we will fix it there. So that is the one technique. Other ultrasound, as recent advances added to the confirmation of endotracheal tube, ultrasound as well as ETCO2, all these things can be used. So other technique is inhalational induction. The advantage with the inhalational induction, we can maintain the spontaneous ventilation, and also in some institutions, if the surgeon want to perform a rigid bronchoscopy, in the inhalational induction, we can perform the rigid bronchoscopy to determine the size and the location of the fistula, and we can plan for the anesthetic as well as surgical management. And it also helps in assisting the placement of the endotracheal tube distal to the fistula if we assess in the preoperative period. So fiber optic bronchoscopy can be used. Carina, identify the carina, pull the endotracheal tube back until the fistula is visualized and endotracheal tube is advanced just distal to the fistula. It should be, as Madam described earlier, it should be above the carina and below the fistula. And some cases may require one lung ventilation. And the problem with the one lung ventilation, infants, if they are so sick, they may not tolerate the one lung ventilation. We have to stop in between, and we have to do the all measures to prevent the desaturation. And the important thing is secure endotracheal tube firmly to avoid any displacement of the endotracheal tube, and avoid other technique is avoid excessive intermittent positive pressure ventilation till the fistula is ligated. So till the fistula is ligated, we will ventilate with the smaller volumes. Once the fistula is ligated, then we can use the adequate volumes. So soft rubber tube or feeding tube is placed into the upper blind pouch. So it helps as the surgeon to locate the upper end of the esophagus. Few centers, what they do is they do the inhalational induction followed by endotracheal intubation, and they give the muscle relaxant only after the ligation of the fistula. In our institute, we generally give the relaxant at the beginning and will secure the airway. So the other problems in the intraoperative period is desaturation and hypotension. This hypotension can be due to the application of this instruments over to the lung tissue and pressure over the heart can result in the hypotension as well as the desaturation. So other causes of the desaturation also we have to see any kinking of the endotracheal tube, any displacement of the endotracheal tube, any blocking of the endotracheal tube. This is also possible because the area of surgery is there only. So we may have to do the frequent suctioning of the blood as well as the secretions. So as we have discussed already, careful administration of narcotics is important as these child are low birth weight or premature babies. So child, even though bright at the time of the extubation, may go into the apneic spells in the postoperative period. So we have to be very cautiously use this narcotics or opioids. Routine non-invasive monitoring is adequate, but only invasive monitoring is required if the child is too sick, hemodynamically unstable, then we can go for the invasive monitoring. That too, radiolateral catheterization to be carried out on the left side, because we'll keep the patient in the right lateral position. So this is the lateral decubitus position to perform the tracheoesophageal fistula surgery, and this is the position of the surgeon, assistant nurse, and will be at the head end. So these are images from our institute. So generally, thoracotomy is performed from the right side. Thoracotomy is performed, and extrapleural approach is performed. So coming to the intraoperative management, all before handing over, all pressure points to be carefully padded, and maintenance of oxygenation is the major issue, and frequent suctioning of the blood as well as secretion to be carried out during the intraoperative period. Hypoxia due to surgical airway manipulation and collapse of the upper lung due to the use of the retractors. Hypoxia due to surgical airway manipulation and collapse of the upper lung due to the use of retractors. And always be ready for the reintubation in case of accidental extubation. So during the intraoperative period, use the oxygen. If the medical air is available, oxygen, air, and sevoflurane combination can be used. If the air is not available, oxygen, nitrous, and sevoflurane can be used. The aim is to maintain the PaO2 between 50 to 70 millimeters of mercury, or SaO2 between 87 to 92% to avoid retinopathy of prematurity, as these children are low birth weight and premature. And prevention of hypothermia is important. During the intraoperative period, we can use the fluid warmers as well as forced air warmers to maintain the euthermia. And fluid administration is to be carried out as per the calculation using Holiday and Sagas formula. And the ideal fluid of choice is Ringer lactate with dextrose containing solution. 20 ml of 10% dextrose plus 80 ml ringer lactate can be added into the due rate of 100 ml. And as per the requirement, calculated amount we will give in first and second hour. So coming to the post-operative considerations, the child without any comorbidities, hemodynamically stable patient, no prematurity is there, we can safely extubate in the post-operative period. If the infant undergoes more complex TEF repairs, elective mechanical ventilation may be required in the NICUs. Consider elective extubation in premature babies, infant with severe pneumonia, any significant associated congenital anomalies are there, any tracheobronchitis, then in those cases, we have to consider the elective extubation. Re-intubation is detrimental to the anastomosis. So once you are 100% sure only, we'll go for extubation. And otherwise, electively ventilate for a few hours or 1 day and safely extubate. And another important thing is nasopharyngeal catheter we place in the preoperative period to be taped or sutured. So what happens if it suddenly comes out, if we want to put the nasopharyngeal catheter again, it may cause damage to the esophageal anastomosis. So once we secure the nasopharyngeal catheter, carefully tape it or suture it properly. For the post-operative analgesia, opioids, paracetamol, caudal block or intercostal nerve block by the surgeon can be used to get the adequate analgesia. Coming to the post-operative complications, there is significant improvement in the outcomes because of the advancement of the surgery and advancement of the anesthesia. Especially the mortality rates are very less than 10% in developed countries and less than 40% in developing countries because of the advancement in the anesthesia and surgical techniques. However, these childs may develop certain complications in the post-operative period. These infants need to be followed up in the further age. Especially these infants may develop esophageal strictures and this child may develop anastomotic leak. These infants need to be followed up endoscopically up to almost 3 years, and a few infants may develop persistent gastroesophageal reflux. So frequent follow-up is required. Few children may develop tracheomalacia. These infants presents with the stridor, apnea, or recurrent pneumonias. So this is the speech survival rates, which was discussed by earlier speaker already. The group 1 is birth weight more than 1500 grams, no major cardiac anomaly. The survival rates are around 98%. If the birth weight is less than 1500 grams or presence of major congenital anomaly, either of this, the survival rates are around 82%. Coming to the group 3, if the birth weight is less than 1500 grams and plus major cardiac, both of are there. If the both are there, less than 1500 grams and major associated major cardiac anomaly, the survival rates are 50%. So this is the summary. Thorough preoperative assessment and proper preoperative preparation of the child is important as it poses so many challenges to the anesthesiologist. So while anesthetizing also proper placement, fixing and care of the endotracheal tube to ensure the adequate ventilation. Even in the post-operative period also, whether to extubate or whether to do the elective mechanical ventilation based on the comorbidities, associated congenital anomalies, we have to discuss. And parenteral nutrition, if required, has to be given in the post-operative period, and the central venous line needs to be secured. And avoid overstretching of the neck. It can cause damage to the anastomosis. So we have to nurse these babies properly. Thank you.
Good presentation, Dr. Venkat. Most of the slides are from our day-to-day experiences. So mostly we discussed about the problems we face regularly. Any add-ons or any questions in the chat box? There is one question. What do we do when the VTT keeps slipping into the fistula? How do we exactly fix the VT between fistula and the carina?
Poverty catheter can be used instead. So intraoperatively, one is bronchoscopy can be used, or to block the Fistula-Puthukkottai catheter can be also used, man.
So the fistula is big. If you want to block preoperatively, we can use Puthukkottai catheter, or intraoperatively, we can perform with the rigid bronchoscopy and we can reposition the tube.
Madam, this one I think slipping into the fistula is a very rare complication because it will be entering in acute angle. So that ETT keeps slipping into the fistula is very rare. It cannot happen. So I think more of a clinical acumen will help rather than instrumentation, like bronchoscopy, Fogarty, because that is such a small trachea, already a tube is in. So these are all the developments. These are all the developments because even now when the pneumonia is extensive, not responding, they are keeping ECMO also as a standby. But these cases, I feel because in 1996 we were doing all these things. Even at that time, even this much facility was not available. So more than instrumentation is to be judiciously used. So that is my feeling. It is up to the moderator to decide.
No, sir. We are also going with clinical equipment only, sir.
That is better always. That is better always because it would be very difficult.
We don't have the facility of rigid bronchoscopy even.
Another one. See, if it is so, I want to have some carry home points for the delegates who are attending. See, the rigid bronchoscopy, as Dr. Preethi pointed out, that rigid bronchoscopy and ABG and all not performed because it is more deleterious. See, picking up an arterial line, because just to measure the arterial gases, a single prick is not allowed. If at all you want to select ABG, it should be a continuous monitoring. That is the anesthesiology principle. It should not be a single, you are not supposed to waste an artery for just one measurement of ABG. It is not possible. At that time only you have to have all these standby like ECMO and all. So that's what I want to say. And Dr. Akhila's lecture, it was really good for a postgraduate. She is very clear in her points. But I want to say for all postgraduates, I used to say T-piece is not a T-piece. It will not resemble the T. That is what I wanted her to say. It is not T. Because the definition of TP systems are not taught to the postgraduates. The definition of TPs is the entry of fresh gas between the patient end and the expiratory limb. It is the TPs. Even Dr. Venkata Krishnan has shown in the slide, that is not a T. The circuit you are not using is not exact T. But the fresh gas enters in between. So it is also a modification of TPs. TPs modifications are enormous. You have mentioned only that because at angle, so many angles it will enter between the expiratory limb and the patient end. So it is not exact T. That's what I wanted to say. I want to emphasize it is not T. So the circuit you are using, even when I was practicing in 94, I think your circuit has more of a dead space. So even I used to cut the endotracheal tube, I will trim. So small things, because already the baby will be premature and a neonate. So you have to reduce, and the circuit which you are using, the circuit that will have more of a dead space. Usually even now, when I am going for anesthesia of a pediatric cases, I used to take my circuit. That was the original TP circuit. It will be T only. Because that is a rubber corrugated rubber tube. Because the advantage is I will not use the bag. I use only thumb occlusion technique for ventilating the patients. So now, because we want to stay away from the patient, and scientifically it is proven to rebreathing, the expiratory limb should be more than the tidal volume. for such a small baby, we are having up to 1 meter length of the tube and we are standing away. That is not the way. So I used to have that routine TPs. It will be exactly T. That is not marketed now because once these plastic circuits have come in, everything is the circuit which you are using. That intersurgical brand is coming. It will be, these are all the things. So we cannot abandon the old practice, especially as far as the pediatric anesthesia is concerned, because that TPs with that thumb occlusion, it gives fantastic results. That's what I want to go. But this lecture was very good. So I think the recording, I will be sending the YouTube recording to many people. At that time, it will hit a major scope because everybody is tremendous. They cannot, everybody is, because what you are practicing, you are talking, then only the clarity will be there. Even the poets used to say, when you have a soul in your heart, then it will be exhibited very nicely. So everyone has done well, and I request madam to concluding remarks. We can conclude.
Yes, sir. Thank you, sir. Thank you, all the three speakers. Sir, actually, what you told is exactly true, sir. When we started giving anesthesia to tracheoesophageal fissure, we are more worried about recovery for the patient. Now it's sophisticated. They are
Yes,
keeping
yes. We can ventilate.
ventilate. So they are not worried about rebreathing and carbon dioxide retention and all, because successfully they are keeping on ventilator and good post-operative care. So not much worried about the circuits and all. Previously, we used to worry a lot because we have to bring the baby out or we have to sit with the baby till next day.
Yeah, the really good, madam, because at that time, if the baby is not breathing and not coming around, we cannot come back home. There is
Yes.
no ventilator. We have to hand ventilate. Nowadays,
Yes.
even pediatricians are ready to take up that ventilation
So
because
we used to carry our
adult
own
ventilation.
tubes and we are concerned
Now
about
this
getting the tube and all.
system is very good. Now the system is very good. When Dr. Venkata Krishnan was telling all these problems, I was recollecting the problems I've undergone. We have operated immediately. We have waited for 2 days, 3 days, and at the end, fifth day we operated and we have lost the baby. So many problems are there because sometimes the haziness. Dr. Preethi has said only the infiltrates will be seen, but we are seeing a homogeneous shadow in the upper lobe. The lobe itself will be out. But at that time, the rebuff from the attendants also very less. That we have to accept.
Yes.
Rebuff.
And the other thing is, after successfully bringing out the baby out, we have to give anesthesia to the baby on 2 weeks, 3 weeks for this stricture esophagus.
Yes, yes. That is right. But once, madam, once we are coming around that initial insult,
the re-anesthesia, which is also very difficult.
He has very specifically said, na, re-intubation is hazardous. It is a disaster. Yes. He has put up some points. This is what exactly we like to have. And you have fulfilled our expectation.
That's why they suggested repeated suctioning of the tube, because most of the time, with the secretions and the blood and the, even though we want to go for post-operative ventilation, the tube is blocked most of the time. At the end of the surgery, there is no ventilation.
But madam, at that time, when not for tracheoesophageal fistula, just because the tube is blocked, because the endotracheal tube 3 will be easily blocked.
Yes.
I'm not talking about a TEF. It is general for thing. When I was in ICH, Institute of Child Health, see, we have a series of tubes. If it is a 3-size tube, we will have 6 3-size tubes by the side. We will not suction. Once it is blocked, we will remove the tube and we will put in a new tube.
So that's why re-intubation also, there is more chance of re-intubation also in the end of the surgery, most common during tracheoesophageal.
But madam, I have to congratulate your team because Dr. Preethi says he very specifically mentioned that the suction is, we have to be very cautious. Low pressure suction, that and all I liked, because once you practice, I liked each and every word, because you are opening batswoman. She was good, your PG. I dropped a message to her. Once the opening batsman hits century, it will automatically go. So she has given a good opening. I have dropped a message immediately to her. I really loved. Any other that is I think madam, if there are no further points from your end, we can go to the next move.
Thank you, sir.
Now I request Dr. Emma, to our treasurer, to propose a vote of thanks.
Thank you, sir. Good evening, everyone. I thank you all for your participation in the 10th episode of the second series of Pudukkottai Bhudhan on the topic Pediatric Assessment on Tracheo Esophageal Fistula by Department of Anesthesiology, Andhra Medical College, Visakhapatnam. I thank Dr. Akhila, postgraduate, Andhra Medical College, Visakhapatnam, on ISTPs and its modification. Dr. Akhila, it was a very precise and well-structured, seamless presentation. Thank you. I thank Dr. Vaddi Preethi, Assistant Professor, Andhra Medical College, Visakhapatnam, on the topic pre-anesthetic assessment of TEF. Madam, it was concise and engaging presentation. Thank you, madam. I thank Dr. Venkata Krishnan, sir, Assistant Professor, Andhra Medical College, Visakhapatnam, on anesthetic management of TEF. It was well commendable presentation, sir. Thank you. I thank moderator, Dr. Aparanji Koturi, Professor, Andhra Medical College, Visakhapatnam. Thank you, madam. I thank Clarinet for your continuous support. I thank our academic chairman, Dr.AL.M. sir, for your guidance. I thank all the participants, faculties, postgraduates, and consultants showing us your continuous increasing support in increasing numbers. Thank you. Thank you all. Have a good evening.
Thank you, madam.
Clarinet, you can go for that concluding remarks.
Okay, sir. So Clarinet is really glad to have all these brilliant people together in this session today. Thank you so much for extending us the opportunity to host the session, and I hope you all had a seamless experience. So with everyone's permission, I'm closing the session today and looking forward to hosting you again. So thank you so much to all, and good night to all.
Thank you. We are leaving.
Thank you.
Thank you, sir.
Thank you.
Thank you, sir.
Thank you all.